while hemophilia B is factor IX deficiency, and hemophilia A is more common compared to hemophilia B. And majority of the case, because it is an inherited bleeding disorder, so majority of the patients will have a positive family history of hemophilia, but in 30% of cases, they doesn't have any family history of hemophilia, but then they still get hemophilia because of spontaneous mutation of the gene. Okay, so this is the inheritance. So you can see at the first picture, the mother is the carrier, while the father is normal. And then for the future children, each of the son will have 50% chance to be hemophilia, while for the daughter, each of the daughter will have 50% chance to be a carrier because they will inherit the affected X chromosome from the mother. Uh, for the second picture, the father is the one who carried the hemophilia gene, but then the mother is normal. So because of that, the son will not be affected because they just inherit the Y chromosome from the father, but for the daughter, they will be the carrier because they inherit the affected X chromosome from the father. And for the third picture, you can see, as I said before, in 30% cases, there will no family history, but then they will have a children with hemophilia. So for the clinical presentation, so usually hemophilia patient, because of the defective of the clotting factor, they will be present with bleeding episodes and also easily bruising. But in neonatal period, usually bleeding is unusual. But then in severe cases, there will be a prolonged bleeding after circumcision. Usually most children will present with bleeding episodes at the end of the first year of life, because during this time, at the end of the first year of life, they start to crawl, they start to walking, and they tend to fall. So it will make them easily to have bleeding. And they can also present with hemarthrosis, which is bleeding in the joints and also bleeding in muscles. Uh, Other than that, epistaxis, gum bleeding, hematuria, and also they will have a risk of intracranial bleeding following a minor trauma. So the severity of the bleeding, it depends on the level of coagulation protein activity. For mild hemophilia, the percentage of the coagulation factor will be 6 to 30%. So they will have the bleeding if they encounter severe trauma or after a surgery or maybe after a dental procedure. For the moderate hemophilia, the coagulation factor usually will be 1 to 5% in the plasma. So they will have a bleeding with a mild trauma. For severe hemophilia, the coagulation factor will be less than 1%, and they tend to bleed spontaneously, to have muscle bleeding or joint bleeding. Okay, so this is the investigations. For the screening test, first is complete blood count. So complete blood count is to measure the amount of the hemoglobin. So for hemophilia patient, the hemoglobin will be normal and can also be low. It depends on the severity and also the duration of the bleeding. Next is APTT. APTT will be prolonged in hemophilia because APTT, it measures the clotting ability of factors 8, factor 9, factor 11, and also factor 12. For PT, PT will be normal because PT doesn't measure clotting ability of factors 8 and also factor 9. To confirm, either it is hemophilia A or hemophilia B. For hemophilia B, so they will conduct clotting factor assay to determine either this is hemophilia A or B. Depends on which type of the clotting factor that are affected. For example, for hemophilia A, factor 8 will be deficient or absent. For hemophilia B, there will be factor 9 deficient or absent. Okay, so for the management, the first one is to prevent the bleeding from happen. So for severe hemophilia, they require prophylaxis. They require prophylaxis because they tend to get spontaneous bleeding, so they need prophylaxis to prevent the bleeding. And then the hemophilia patients also needs to avoid intramuscular injections because it can lead to muscle bleeding. They also need to avoid aspirin and also NSAIDs because these two will decrease the platelet function. Next is if the bleeding already occur, then we need to stop the bleeding. So the treatment is recombinant factor 8 or factor 9. It depends on the types of the hemophilia. So the dose given to the patients, it depends on the bleeding site, chart weight, and also serum half-life. Uh, if the bleeding is occur in the joint, so usually clotting factor need to be raised to 30 to 40%. If it is a soft tissue or muscle bleed, aim for 40 to 50% of the coagulation factor. If the patients need to undergo major surgery or have intracranial bleed, then the coagulation factor need to be raised to 100%. So below is a formula of the calculated dose. So the percentage desired times with body weight and times with constant. And then the next treatment is desmopressin. So this is given intravenously to treat mild and also moderate hemophilia A because it will stimulate the endogenous release of factor 8. But desmopressin is ineffective in hemophilia B because it doesn't stimulate factor 9. Next is tranexamic acid. So tranexamic acid is antifibrinolytic agent, which it will be used to treat oral bleeding, epistaxis. Next is supportive measure, which is use a price guideline when there is any bleeding. So P is referred to pressure of the dressing. R is rest. I is ice. C is compress, and E is elevation. Next is home treatment. So home treatment is where the parents will be taught on how to administer the medications, the treatments to the children because the children, especially to the young children lah, because the young children cannot administer by themselves. If anything happen at home, if the bleeding happen at home, so it will be managed appropriately. And all the hemophilia patients also need to be registered with Hemophilia Society and they should have a medic alert bracelet or chain. Next is prevention or management of the complication that might arise because of the bleeding. So all hemophilia should be immunized against hepatitis B. This is because the treatment, the infusion of the clotting factor to their body carry a risk of a viral transmission, for example, hepatitis B, hepatitis C, and also HIV. So that's why they need to be immunized. Secondly is regular physiotherapy. This is to prevent muscle weakness when they have a recurrent joint bleeding. Then is regular inhibitor screening. So hemophilia patients, due to the treatment, they also have a risk of developing inhibitor, which is the antibody that directly against the exogenous clotting factor that administered to them. So because of inhibitor development inside of their body, they tend to not respond to treatment. So that's why hemophilia patients need to undergo regular inhibitor screening. And lastly is the complication. So due to bleeding, recurrent joint bleeding can cause chronic arthropathy and depends on the severity of the blood loss. If it is severe, then it can cause hypovolemic shock. Also in hemophilia patients, they will have a risk of intracranial bleeding. Due to the treatment, as I said before, the transmissions or the treatment of the hemophilia carry a risk of virus transmission, for example, hepatitis B, C, and also HIV. And they will also having a risk of inhibitor development. So if there is inhibitor development, so usually to treat the bleeding, doctor will require high dose of factor 8 or factor 9, or maybe they will require bypassing agent, which is recombinant factor 8A or FIBA in order to treat the bleeding. Okay, so I think that's all for me.
Okay, thank you. Any question by others? Can you hear me?
Yes.
Okay, any question you want to ask Sabrina?
Sabrina boleh ulang balik tak yang price tu, yang supportive measure? Saya tak sempat.
Oh, sekejap Okay, okay. So this is when the bleeding occurs. So this is the price guidelines, which is P is pressure of the dressing, R is rest, I is ice, C is compress, and E is elevation.
Thank you.
Okay.
So how do you know the severity of this yeah. How if you were to assess the severity of this hemophilia?
Depending on the level of the clotting factor in the plasma.
Okay. So how do you classify?
Uh, I will classify based on mild, moderate, and severe. And if mild, then the percentage will be 6 to 30%.
Okay.
Moderate,
Okay.
1 to 5%.
Okay. Another thing is how to say if the patients come to you, okay, how do you know that the patient might be having risk for um intracranial bleed? So meaning that under severe, isn't it?
Yes.
So what is
Severe.
your treatment if the patient is so-called in severe bleeding of hemophilia? Because you're afraid of intracranial bleed. So if the patient is having spontaneous bleeding, okay, meaning that there is bruises, they come to you to the ward and we take the level, isn't it?
Yes.
So based on the level, okay, so you think that this patient might be having intracranial bleed, the risk of intracranial bleed. So what is your principle of treatment for this type of patient?
I think because we already know that this patient is a hemophilia, so I think the infusions of the recombinant factors.
No, how much you want to give to the patient? There is a calculation, isn't it?
Yes, betul. The dose is depends on the site of the bleeding, the child weight, and also the serum half-life. So in case of there is intracranial bleed, so the percentage desired is 100% of the clotting factor. So
It
times
is
the
not yet. It is not yet intracranial bleed, isn't it? There is a risk of intracranial bleed.
oh
Okay, kalau ada tu memanglah. But if you look at the clotting factor, I mean, you go by what is the percentage and it is
mm,
very, very low. So you have to treat as such because you don't want the patients to be having intracranial bleed. Okay, understand? So that's why you're
yes.
using that formula. So
Oh,
satu lagi, I think you have mentions about the about the inhibitory, isn't it? Just now, I think that one is fine enough to say how to manage the inhibitor, okay, the presence of inhibitor.
yeah.
But if how would you counsel the parents, especially for the genetic so-called counseling?
Oh, genetic counseling. I think we need to tell them about the nature of the disease, which means
Anything
like
else? Genetic counseling.
the children will tend to get bleed easily
No,
and
no, this is genetic counseling.
or genetic
No,
counseling means like
you are not really you do not really like a usual punya counselling. Yang you cakap tu is a usual counselling, isn't it? You mentioned about the severity of illness, what the patient will be having. But for genetic counselling, for this patient, how?
uh, uh, draw the
For example,
pedigree.
the first child, the patient is first child, and then you investigate. Okay, you do the workup, and the patient is having hemophilia. Okay, so you would like to counsel the parents, isn't it? So you are
Yes.
basically doing the genetic counseling. So how you want to mention to the mother, to the parents, sorry.
By doing I think first we need to draw a pedigree table so that we can show to the mother that they will have a possibility to have hemophiliac children in the future.
So how?
How? How
You
to
you
draw
want to,
kan?
no, you want, this is genetic counseling. So bila you genetic counseling, you are mentioning about the percentage of the pregnancy. I
Uh,
want to assess you punya understanding. Present, maybe you take from somebody else. So this one, I'm assessing your understanding. So you just mention, I know you already present, but how if you were to talk to the mother? And I gave the scenario that this is the first child, okay? How?
I want to know that either the both parents is the carrier or have hemophilia.
What do you mean by both parents are carrier?
No, I mean that if we detect that the first children having a hemophilia,
Okay.
but we doesn't know that either the parents either the father have hemophilia or not, and then either the mother is a carrier or not.
No, kalau dari segi genetic counselling, what are the first thing that you will say to me in exam? You will say that this is,
X-linked recessive.
so this is X-linked. Okay,
Uh,
what happened in X-linked?
the male will be affected. Usually the male
So
will
we're
be
not talking
affected.
about family screening. We are talking about genetic counselling. The one you mentioned that siapa carrier semua itu dipanggil family screening. So you'll be taking the parents kan. Itu adalah family screening kan.
Uh,
Okay, but I suppose you want to know whether this is, I suppose, mutation lah kot
oh
because
yeah.
if the father is already having, then we know already that the father is having hemophilia. But if I mention to you that most probably that the question is most probably that the parents don't know about this, so suddenly that the child is having hemophilia kan, or mother doesn't know kan, mother doesn't know that she's a
Carrier.
carrier. Okay, she's a carrier. So when you want to, I mean, at least you ask me whether the child is boy or girl, because the first word you want to say is the X-link. So maknanya if you tell the mother that this is X-link, maknanya how many percent chance?
I'm sorry, doctor, I can't hear you.
How many percent chance if the mother get pregnant again in future? How many percent chance of having hemophilia?
If is the mother is a carrier?
Okay. If the mother, if this child is having hemophilia,
Okay.
so what is your anticipation?
I'm sorry, doctor. I don't understand what you mean by anticipation.
The patient is having hemophilia.
Okay.
So how many percent that the mother is a carrier?
50%.
50% only the mother is a carrier if the child is a hemophilia case.
I think 100%.
100%? What do you mean by 100%?
Uh,
But how do you counsel a patient with hemophilia? So what happened to next pregnancy?
if the mother is a carrier, then there will be a 50% for each of the son to get hemophilia.
Which particular son? Which particular child?
Son. Each son will get 50% chance to get
So
hemophilia.
maknanya if the mother pregnant and the fetus is a boy,
Uh,
so there will be how many percent chance?
50% lah for the next pregnancy.
For what?
For the son.
For the son what? Ayat
For the
balik
son.
lah if you
For
want
the
to ask
son.
the parents.
So, if the mother having a pregnancy later on, so there will be a 50% chance for each of the son to get hemophilia.
Another 50%?
Another 50% would be normal.
Okay, so you jawab laju sikit lah. So
Okay.
I think kalau misal kata hemophilia ni, usually we understand that kalau patient tu is a positive, more highly chance that the mother is a carrier, isn't it?
Yes.
Kan? Is a carrier. Cuma kita kena buat screening lah for the mother. Kan? Cuma highly chance that the mother is a carrier. So every time we need to know the sex of the patient. If you said that macam tu lah, you kata 50% each daughter carrier tu, maknanya you bagi scenario differently. You said the mother. Macam yang I tanya lah, it must be the first box kan. So if you know the sex of the fetus, it is 50% chance of normal, 50% chance of hemophilia. If you know the sex is a girl, then 50% chance of a carrier and 50% chance of normal. But
Yes.
if you don't know if you don't know the sex, maknanya there will be how many percent? Still the same. How many percent chance of getting hemophilia?
25%.
Okay, 25% chance of getting hemophilia and 50% chance of
Normal.
normal and
25% will be carrier.
25% chance of having carrier. So those are the genetic counselling part. But the one that mentioned just now is the mutation kan. Semua that one tu macam it's a little bit complicated lah. Okay. So I think I suppose you need to know about the cascade, isn't it? For this disease, for you to know. For approach of bleeding tendency, you need to understand the cascade. And from there you can basically work out lah. Okay. So any question from the floor before we move? Okay, thank you. Quite clear, short and sweet your presentation, Sabrina.
Thank you, Prof.
Okay. Ada soalan lagi ke atau we can move to the second topic? Second topic by maybe Asma kot Nazla. Aha. Aha. Okay, now we take the further. Sekejap I tengah tak dengar lah soalan you sekejap kejap ke ni suara? Okay. Can you repeat? Aha. Mhm. Okay. So, okay. Anything you want to say, Nazla? About asthma? Short and sweet lah. Short and sweet lah. Panjang-panjang nanti terlena pula kita. It's okay. You can basically, okay, boleh aja, tak ada masalah. So you also want to put the slide, okay? Okay. Again. I suppose you have to go by the age of the patient, so easier, isn't it? So but that also the same. There are many causes of wheezing, isn't it? So recurrent wheeze, there are many causes. So fair enough to exclude your diagnosis. But at the same time, you have to support your provisional diagnosis. So maknanya you exclude, but the patient must fulfill. Like today, I think in the clinic. So, but today, this is under hyperactive airway disease. So asthma is hyperactive airway disease. So what we review in the clinic is patient with apa benda dia panggil BPD. Apa BPD? What is BPD? Nama lain dia bronchopulmonary dysplasia. Pernah dengar? Or other name is chronic lung disease. So patient akan mimik asthma kan. So kalau certain age, whether you want to label the patient as BPD or you want to label the patient as asthma. But everything is under umbrella of hyperactive airway disease. So that's why I said we support. I mean, you have to support the diagnosis of asthma also, not just exclude your differential. Maknanya dalam asthma mesti ada wheezing, mesti ada nocturnal cough, and the keyword is that the patient need to be improved with your bronchodilator, isn't it? Okay, continue. what do you mean by pulse oximetry you use as investigation tool? Pulse oximeter, isn't it? Pulse oximetry, it's not really an investigation. It is always an examination for me. Sama juga dengan peak flow. For me, it is peak flow. Peak flow, yeah, usually we put in the examination, isn't it? But I don't know, it is not really purely the investigation. But if you were to use the pulse oximeter, basically you want to know about the patient response. Okay, when you give the bronchodilator, I don't know if like that. Maknanya, if the patient pulse oximeter, for example, 90%, and where you give the bronchodilator, salbutamol, nebulization, but it must be in the acute exacerbations that the patient is improved. So you can use the pulse oximeter. But I mean, that is a common sense lah. But it is not purely like very so-called, how to say, confirmatory, is it a confirmatory test? Maknanya how strong is the sensitivity and specificity of the investigation, isn't it? If you, but the keywords for asthma is that they have very fast response to bronchodilator. So those are the keywords for asthma as compared to the other types of hyperactive airway disease. Okay, so that is my answer. So is there any other questions to the presenter? Okay, thank you Nazla. And ada soalan from your colleague? Okay, other people present not doesn't mean that you did not prepare. So I also will ask you, the other friends, for me to give marks. Because portfolio ni ada dua benda. One is for the tempat you untuk kita discuss and bertanya lah, portfolio. Another thing, because we have to push you study. So to some extent there is a mark for portfolio. So that's why I'll do the assessment so that I can give you marks according to certain things lah yang telus. So any question?
Doktor nak tanya, for macam during diagnosis kan, kita kena cakap ke the severity of acute asthma exacerbation tu?
When?
Contoh kalau macam, contohlah kalau macam ada case kan, lepas tu kita kena, bila doktor tanya apa diagnosis dia, kan kalau kita just cakap asma juga ataupun kita kena include yang kotak terakhir, ada yang kotak yang Nazla masukkan, yang severity of acute
Nazla,
asthma.
what is your answer, Nazla? So this one is the scenario in the ward. I suppose in the ward, because clinic you delete the first part. You delete the first component kalau clinic. So in a ward, how you put the diagnosis kan? Soalan you how you put the diagnosis kan? I know, dalam ward case. When you clerk a case, you have a diagnosis kan? And the reasons for admission for the patient is the patient is having shortness of breath because of asthma. So what should you put in your diagnosis, Nazla? What do you mean by classification, Nazla? So asthma by right is a complete diagnosis. Okay, complete diagnosis.
Oh, okay.
So you cannot put just asthma. So apa yang you kata classification you tu? Tunjuk balik. Tak boleh ingat lah. So if you go by this, maknanya, no, if you put the diagnosis, misal kata patient ni umur 7 tahun, okay, the 7 years of age and the patient has been diagnosed asthma for the past 2 years, okay, 5 tahun dia diagnose as asthma, now 7 years, and the patient was on inhalers juga dengan on steroid prophylaxis, both, okay, and kalau you classify dia bawah persistent lah sebab patient ada dua-dua, so dia adalah moderate punya persistent asthma, and currently the patient came and patient is tachypneic, unable to talk in full sentence, and saturation dia 90% under room air. Okay, so how respiratory distress. Okay, Nazla, how you put the diagnosis for my case scenario? Maknanya 7 tahun, diagnose 2 tahun lepas on treatment, attack almost every week lah kan, every week. Okay, and then dia datang dengan tachypnea, respiratory distress, saturation 90% under room air, and the patient's unable to talk in full sentence. However, the vital signs still okay, and the heart rate tu tachycardic lah sikit, tapi okay. Speed flow about 60%. So how do you put the diagnosis for this patient? Complete diagnosis. Complete diagnosis.
Moderate.
Complete diagnosis.
Is it moderate acute exacerbations of persistent that the doctor mentioned? Persistent asthma.
Complete diagnosis apa? I know ke siapa jawab? I know. What is your complete diagnosis?
I'm not very sure. I try doctor. Is it moderate acute exacerbations of persistent asthma? Is it?
Salah.
Tak tahu.
Nazla. Ni yang lain tu senyap tu kan tu bapak patah rendah pula. Okay, I know you did not. Okay, because you did not come to the ward yet kan. So there are two component history. There are two component of the diagnosis. So satu is for current punya diagnosis whereby the patient is having acute exacerbation. Kalau you lost boleh tahu because you did not come to the ward yet.
Okay.
Siapalah yang senyap tu biasa lost. Yang cakap banyak tak lost sangat biasa. So satu komponen why should the patients come to the ward, dia ada acute exacerbation. So we have to classify lah dia punya severity tu. So kalau yang I tengok depan mata I ni, I rasa I bagi semua contoh tu 60%. Kan I cakap salah. So
Moderate betul-betul.
Macam mana jadi moderate pula? I thought I giving all everything for the severe.
Oh, less than 60 ke? Okay, salah dengar.
Depan mata dah. So patient is having severe acute exacerbations of bronchial asthma, severe AEBA, secondary to what? So ada satu diagnosis, acute diagnosis, maknanya severe acute exacerbations of bronchial asthma. Secondary to apa? So is it infection, maknanya is it acute tonsillitis, is it pneumonia, or is it the provoking factor is cold weather, is it certain foods? Understand? So faham? Severe AABA secondary to what? Because your management akan ada dua komponen. Satu, you treat the severity dia. Satu lagi, the provoking factor. Something yang you boleh treat lah, for example, infection. Tapi kalau misalnya kata cold weather, you cannot do anything with the cold weather. But if cold because of aircon, you can adjust that part. Sama juga if it is dust. So certain apa dia panggil preventive measure can be done to the patient kan. Cuma kalau infection, then you would like to treat the patient with antibiotics. So this is the first component. So maknanya dalam ni ada 1, 2, 3 komponen, okay. Ada severe, first component. Yang kedua, acute exacerbations of bronchial asthma, second component. And the third component is the provoking factor. Okay, satu diagnosis. And the second diagnosis, we want to know whether is this patient is newly diagnosed asthma or the patient is a known case asthma. So I give the scenario that the patient is a known asthma. So bila known asthma, you want to know how is the severity, dia go by frequency, isn't it? Because if you use the previous GINA, dia ada intermittent asthma, dia ada persistent asthma. Persistent can be further divided into mild, moderate, severe persistent asthma. So this is the underlying, okay? Okay, the second row for this patient is underlying, apa tadi ya? Mungkin you kata moderate persistent asthma ataupun underlying mild persistent asthma. Okay? Kalau intermittent tu very rare lah, intermittent asthma. Okay? And whether kalau newly diagnosed, you will say newly diagnosed asthma. Okay? So maybe for newly diagnosed asthma, we cannot really judge. Boleh dengar ke? For newly diagnosed asthma, we cannot really judge because maybe inadequate information by the parents because the parents are not really observed the attack yet, not really aware of the exercise-induced asthma or nocturnal cough. So we have some deficit in labeling the patient, kan? So maknanya we educate the patient first, the parents first. So satu, kalau you nak elaborate lagi whether it is compliance, control, not control, so that you can comment. So maknanya kalau patient is having moderate persistent asthma. So is it control or poorly control? So because kalau kata poorly control, so you might want to improve your education and you might need to step up. Okay, you might need to step up. So kalau daripada moderate, you have to put in severe. But if the patient is having improvement, so you kata control. So you might want to step down. Okay, the management. So there is also contributions to your management for the second part. Okay, so is it answer your question, Nazla? So dia ada banyak komponen lah. Satu, kalau asthma ni markah saja minimum 5. Okay, nombor satu barisan pertama 3 markah, nombor 2 tu adalah 2 markah untuk ni. So if you put just asthma saja, maybe you ada dapat daripada 5 you dapat setengah markah saja. Okay. Okay, any other question? So if I were to ask Nazla, so go by the pathogenesis. Go by the pathophysiology or pathogenesis. Anything you want to say about the pathogenesis or pathophysiology? Yang ni mungkin tak ada dalam slide. So roughly what is that? No. This is pathophysiology or pathogenesis. We are not talking about this asthma yang clinical findings. Ada ke tak ada? So we have to talk about hyperresponsiveness tu. Ada kat sini kalau tak nampak. Because this is very because asthma dia ada IgE related, dia ada non-IgE related. So kalau kata IgE related, then you can do the peripheral blood smear the eosinophil will be elevated because dia adalah IgE related. But if the asthma is non-IgE related, then it will support by your eosinophilia. Kan, satu. Tapi kita ambil yang common things lah, which is the standard, which is eosinophil punya so-called IgE related lah, IgE related. Kita ambil yang standard IgE related. So ada 4 ataupun 3 kan, pathophysiology or pathogenesis. So others? Ni I nak faham, ni I bagi markah untuk you punya understanding. To avoid people taking from your friend portfolio, because as I mentioned, the keyword is understanding. So you nak kena tengok apa dia punya common sense, hyperresponsiveness, lagi apa, mucosal, apa dia panggil, swelling ke apa ke? Boleh, tak dapat? Kenapa berlakunya asma? So what happen kalau kata hypersensitivity? The consequences of lagi? What do you mean by paru-paru? What do you mean by paru-paru? So tengok, you cannot get marks because you're talking like patient is having fever, demam. So what happened to the airway tu? What happened as a consequences of the one that you mentioned just now? What happened to the airways of the patient contributing to the wheezing? That one important. This one is very important. This one yang basic for third year. You maknanya I know that clinical is one, but for third year very very important, pathophysiology or pathogenesis. So tak boleh jawab? Lagi? Itu ada pathophysiology of wheezing. Ini asthma. So anybody who's having wheezing will be like that. Tapi untuk asthma itself, tak pasti tu maknanya tak boleh lah. Okay, my second question is apa Ada soalan ke kawan-kawan nak tanya? Kalau tidak, I tanya yang tak bertanya.
Basically, I have questions regarding the investigations that we done. It stated that first is spirometry, but then Nazla said just now if it will be done if in case that the patient be able to do it, but how about if how about if the patient cannot do the spirometer, so what kind of investigation?
Tak, dia bukan tanya soalan tu, common sense lah. Kalau nak naik kereta, do you expect 5 tahun bawa kereta? That is your question. Ada
Oh,
kereta.
no.
Nak suruh 5 tahun bawa kereta. You
No.
want to ask the question, why you cannot drive?
Oh, no.
Huh?
Huh?
Kan? So is that your question?
No, I want to ask what is the investigations that we done to the type to the children that does not be able to do spirometry in order to diagnose asthma.
How do you diagnose asthma, Sabrina?
Based on the spirometry.
Siapa kata? Ramai orang tak buat spirometry, we still diagnose the patient as asthma and happily the patient on inhalers. If the patient is not control, kan? If the patient is not control with your inhalers, then maybe you do, kan? Kalau you ada limitation, you do USM, misal kata kita tak ada alat tu. So is it that we cannot treat the patient with asthma because kita miscan dan kita No, isn't it? To say that it is not mandatory, kan?
Oh, okay.
Kan? Yes, ideally you have to treat. Tapi kalau patient dekat Besut Hospital and then if you want to refer to Kota Baru or here but because of the full house, so the patient cannot, the investigations cannot be performed because of full house. So then you cannot diagnose the patient of asthma because of the limitation that full house of the appointment or maybe because of distance, okay? From Gua Musang, for example, the patient cannot come, very difficult to come. So is it a limitation that you cannot diagnose the patient as asthma? No, isn't it? You still can diagnose the patient as asthma and you treat as such. The problem is if you have in adult, okay, ayatnya adalah in adult. If you have a case which is not, kita panggil apa, which is not controlled with your treatment, you have to do everything, you have done everything to the patient, you educate the patient. Patients are very, very good, comply to your what we call nasihat, advice, okay? And you think that the treatment is okay, but the patient still, talking about the provoking factor, ada banyak lah, and there is a genetic component, isn't it? So I suppose in a patient who is intractable, fair enough, it's a must for you to do spirometry because as I mentioned just now, the keyword is for asthma, very, very rapid, okay? Very, very rapid response to your, because dia adalah obstruktif, dia bukannya restriktif. So bila spirometry, kita ada dua, kita ada restriktif, kita ada obstruktif. So untuk asthma, dia adalah obstruktif, dia bukan restriktif. So kalau patient tu is restrictive lung disease and you give the bronchodilator, so there is a chance that the patient is not improved. Understand? So that's why you want to confirm that, okay, this is asthma, not restrictive lung disease. So you proceed and you found that the patient is a case true enough based on your suspect, okay? Maknanya kalau case tu adult pun kalau dia tak nak dan ada some limitation, I suppose it is okay. But ideally, yes, you proceed with spirometry. But if there is limitation, it's okay. But the keyword is the patient need to be improved. So if the patient is not improved, then spirometry is a must because you want to exclude other diagnosis. Why should this patient is not response with the ordinary or standard treatment for asthma? Okay, regardless that, bukan regardless, maknanya you have to make sure that the patient is comply lah. Maknanya kalau tak comply, don't talk about control lah kan kalau treatment is not comply. So dia common sense lah, sama juga dengan patient you did not do the cerebella or you did not do the cranial nerve in 1 year of age patient. So can't you diagnose the patient as neurological disorder if you cannot perform to some extent certain neurological examination? No, isn't it? Kan? Bukan. Cumanya spirometry, yes, adult is a must lah. Tu pun bukan semua. Okay, there is some limitation. Tapi yang tak kontrol wajib buat. So sama juga dengan pediatric age group, I suppose we will basically push for spirometry if the patient bigger child, okay? yang kita kata not really improve with our medication because it's a differential diagnosis basically. Or maybe I don't know kalau kenapa you patut 100% you need to do spirometry. So maybe you would like to prevent the complication related kan. I mean if you did not proceed with spirometry, is there any delay in certain medication or not? Based on my knowledge, no. Ada tak delay in medication if you did not do spirometry? Maknanya if you do spirometry then you can give certain medication. Kalau tak buat tak boleh bagi, ada tak macam tu? Tak ada. So that's why I said cumanya kalau kita kata tak perlu buat, marahlah respiratory physician. That one is wrong say. Maknanya ideally you buat. Faham?
Faham.
If there is a limitation then we have to, kita patut do dengan whatever we can lah. Tapi kalau tak compliant, kalau tak control definitely kena. Because kalau misal kata dia memang betul-betul obstructive, so maknanya our medication is not yet, tak cukup lagi lah. So I don't know apa benda yang nak mencukupkan tu. Whether dari segi steroid ke apa bendanya kan. Maknanya steroid ni oral medication we did not give long. So I don't know kalau patient ni maknanya dari segi whether if you balancing with the side effect, you really need to give the steroid. I don't know that one. Okay. Because for me kita tak ada lah kan. Kita pun baru ada je respiratory physician. Kan. So kalau tak ada, and here we don't have respiratory physician for pediatric, so we send to Dr. Marana, HRPZ. Okay. So I hope it answer your question. Maknanya yes, kalau misal kata the keywords adalah you diagnose asthma patient ni based on dia punya presentation. Keywordsnya adalah the patient need to be improved with your bronchodilators. However, if the patient admitted and they admitted because of the pneumothorax, so they admitted with severe pneumonia, and again if you give nebulization, it won't have a very rapid punya response, isn't it? Because the patient has complication related. So maknanya you tengok lah, maknanya kalau I kata rapid ni the timing is about 5 minutes, okay? So when you give the bronchodilators, you give the salbutamol, harap the patient should be less ataupun better or comfortable, depends on the mild, moderate, severe tu response to our nebulizations 5 minutes, okay, 5 minutes, unless the patient is having complications related. Okay, siapa tanya? Sabrina?
Yes. Yes, thank you.
So maknanya spirometry buat bagus, tapi kalau tak ada, nak buat macam mana? Tapi ideally yes, okay, ideally yes.
Okay.
Kalau doktor tanya Dr. Mariana, dia akan kata semua patient yang besar-besar perlu buat lah. Kalau kata patient kecil-kecil macam mana nak buat?
Okay.
Any other question? Alia ada soalan?
Ada. Nak tanya, ada. Hello, dengar tak?
Boleh dengar.
Nak tanya ni, yang pasal slide nombor 6 tu, yang dekat clinical findings tadi tu, Nazla. Why are the symptoms often worse at night or early in the morning? Is it due to the cold weather ataupun ada something yang memang spesifik yang menyebabkan symptoms tu worsen?
Which one? Yang step mana ni?
Yang ada yang tu, yang note tu.
Note mana pula?
Ada yang kecil bawah kiri. Betul.
The symptoms often worse at night. Okay, this
early
bukan nak jawab Nazla. Mana temperature? Don't say temperature. Is it orang panggil temperature?
Weather.
Temperature ni bunyi macam demam pula. Okay. So maknanya? Maknanya? So, okay, kalau you club patient, you should understand what is asthma kan. So, asthma ni dekat mana obstruction dia? Nazla, kat mana obstruction dia? Airway dekat mana obstruction? Kat mana? Airway tu which particular level? Is it the trachea? Is it the bronchial? Is it bronchial aku? Bronchial asthma.
Bronchus.
Asthma. Bronchus? Ha?
Bronchial.
Bronchitis, bronchial asma, bronchial lah.
Bronchial.
Tracheitis, trachea. Dia tanya soalan. Okey, level dia adalah bronchioles, isn't it? Kat bawah lah, dekat ujung-ujung lah. Okay,
Bronchial.
levelnya dekat situ, dia panggil airway obstruction lah kan. So, airway obstruction. So, you tak faham dari segi pathogenesis tadi, tak faham pathophysiology. So, IgA or non-IgA related, at the end of the day, they increase the secretions, isn't it? Mucosal edema kan. So those are the things happen in asthma patient. Okay. So the triggering factor, as we mentioned, is it IgE related or non-IgE related? So if you're talking about cold weather, it is non-IgE related. If you're talking about the dust, kan, mungkin ada allergen, mungkin ada IgE related. Boleh? Okay. So itu, so maknanya satu lagi is the patient will be having wheezing. Okay, dalam asthma dia ada recurrent wheeze. Okay, keywordsnya recurrent wheeze. Okay, so wheezing, semua yang ada wheezing ni dia panggil hyperactive airway disease. So asthma adalah hyperactive airway disease. Okay, so if the patient came with recurrent wheeze, so you tengok umur patient. Misal kata sekali dia berlaku wheezing. So sekali dia berlaku wheezing, is it associated with fever or not? Okay, or not associated with fever. So kalau dia associated with fever, you want to blame the infection. So what are the infection can cause the wheezing kan? So those are the differential diagnosis. So boleh Boleh faham? So maknanya how do you know that the patient is having asthma? Satu, maknanya is it clear that there is a provoking factor. So other than URTI symptoms or pneumonia, the patient is triggered by cold food, dust, food yang macam rambutan tu kan. I don't know lah kalau kata rambutan, is it the sobat yang manis sangat ke ataupun is it sebab kadang-kadang kulit dia tu kan, dia panggil apa, lekang tu. Tapi kadang-kadang you makan rambutan yang tak, memang kulit dia okey, kulit dalam tu, kulit biji tu, bukan kulit berbulu tu. Okay? Because
faham.
so kadang rambutan is one of the culprit, okay? So I have read something lah, I don't know, cuma whether the manisan tu sangat sampai terbatuk ke, I don't know. Cuma is there any mechanism tak yang manis tu dia trigger dekat, I cannot remember in detail. Cumanya common sense nya you kata tak lekang tu. Bila kulit tu kan, kulit kat biji tak lekang tu, dia selaput tu, dia mungkin akan irritate our throat. So that's why the patient's coughing. But if you want to say the sweetness of the rambutan, I don't know lah. So maknanya, there is certain triggering factor yang accepted for asthma. Yang tadi itulah kan, cold weather, semua-semua tu triggering factor. So satu, maknanya tak ada penyakit lain yang akan menyebabkan triggering factor except for asthma. So, okay, satu lagi is exercise induced cough. Okay, exercise induced cough maknanya if you want to cloud the case, the patient must be at the level of already able to run. So kalau patient just crawling, okay, or maybe sit, so tak payah sebut lah exercise induced cough ni. Exercise induced cough ni sepatutnya berlari-lari. Okay, yang berlari-lari. Okay, so those are the common things. And then as mentioned just now, the nocturnal cough kan. Nocturnal cough tu malam. So malam biasanya lebih sejuk daripada siang hari. So when you talk about nocturnal cough, kadang-kadang kita cakap early morning cough. Okay. So nocturnal ataupun early morning cough. Sebab kalau pukul 9 malam mungkin tak batuk sangat. Depends lah. Depends. Tapi biasanya early morning cough. Okay, sebab cuaca lebih sejuk pada masa tu. Okay, cuaca lebih sejuk pada masa tu. So that's why kata suhu lebih sejuk. Tak tahu bila guna temperature tu ialah indirectly lah kan. So that's why kita kata early morning cough, nocturnal cough. Satu lagi adalah nighttime awakening. So if you say about nighttime awakening, usually it is more severe than nocturnal cough. Because kalau kata nocturnal cough, patient mungkin batuk saja. But kalau nighttime awakening, patient will awake from the sleep. So I suppose kalau kata nighttime awakening lebih severe because kan, sebab mungkin dia sampai breathing dia tu block, I don't know, sampai satu tahap then dia wake up lah kot tak? Betul tak? So maknanya kalau patient you nak diagnose asthma, patient mesti ada semua benda tu. The provoking factor, exercise induced cough, early morning cough, nighttime awakening. Itu dipanggil daytime symptoms and nighttime symptoms, which is only for asthma, bukannya benda lain. Okay, bukannya untuk orang lain. Itu adalah hallmark, okay, identity untuk asthma. Identity untuk asthma. Cuma dia adalah mimicals kan, kalau kata cardiac asthma. Cardiac asthma ni bukannya asthma. Cardiac asthma basically patient who's having heart failure, okay. Cuma dia mungkin ada wheezing, but the wheezing is not due to asthma. Yang ni dia adalah wheezing because of heart failure, okay. So yang tu pun dia panggil cardiac asthma. Treatment mungkin lebih kurang sama, but you need to put the anti-failure treatment lah under you punya ni. So satu lagi, for you to say asthma, the age of the patient must be more than 5 years. So kalau patient less than 5 years, tak panggil lagi asthma. 1 tahun, 2 tahun tak panggil lagi asthma. Panggil benda lain dulu. So more than 5 years. I think nowadays the current teaching is more than 5 years. Ada nocturnal cough, ada wheezing provoked by infection. Dia panggil apa tak dia? Maknanya kena lebih pada 5 tahun. And then maybe kalau kata 5 tahun ni, the positive things mesti positive family history of atopy, asthma. So higher chance that the patient is having asthma kalau ada family history of atopy. Boleh. So dia tak ada, maknanya kalau you examine the patient, kalau patient tu you tengok monthly punya nebulization and then mother claim there is nocturnal cough, then you have to examine for a signs of chronicity. So Nazla, kalau you want to examine the patient for signs of chronicity, so what are those? Tadi you sebut dah kan? Kau tak sebut, dijavu pula. Ada you sebut eczema dah tadi? Okay, so kalau kata patient, when you examine the patient, yang tu salute sign kan? Tu salute sign. So hidung dia tu mungkin ada garisan atas hidung. Itu dia panggil salute sign. Salute sign sebab dia gatal hidung, so dia masalah tak apalah garu macam tu. Hidung gatal tu kita kalau garu lagi kembang lah hidung. So kan? So masalah tak apa garu macam tu. Cuma bila dia letak dengan tapak tangan dia, hidung dia macam tu. So atas batang hidung tu mungkin ada garisan. Mungkin ada garisan. Yang tu dipanggil salute sign. And then bila dia gatal, mata lah. So dia akan scratch mata. So you akan tengok ada macam blue sikit kat mata dia tu. Anak Mak Saleh nampak merah lah. Anak kita akan nampak macam kita hitam sikit lah. Kalau kita umur macam kita sekarang, you jangan garu sangat, lagi hitam lah. Okay? And then itu adalah satu sign. Sign lain tu yang you letak kat sini tu lah. Which is the, which is the eczema itself lah. Ataupun dia dalam satu kategori tu yang you tulis kan. Is it rhinitis, conjunctivitis, sinusitis. Semua tu kalau ada eczema, maknanya ada signs of eczema. So kalau patient asthma, on examination you kena cakap, is there any dry skin or not? Kalau history pun you tanya, but you have to support. So kalau patient semua ada yang ni, so lagi ni lah. Satu you dah letak dah ni, tanya chronicity tak? Boleh nak jawab laju tak dia? So maknanya the patient is having poor weight gainer. But once the patient is diagnosed to be having asthma, satu kita kata uncontrolled asthma can be contributed by obesity. Because malam if you obese, there is a tendency for obstructive sleep apnea kan. So kalau patient obese, kalau asthmatic, so higher tendency that the asthma might not be controlled. Okay, obesity, patient yang chubby. So that's why kena jaga jugalah. Kat mana lagi so maknanya you go by patient who's having poor weight gain, lepas tu ada features of atopy yang semua listed ni. And when you examine the patient, Nazla, apa lagi points to say that okay, this is asthma, bukannya benda lain. Satu lagi, you will examine the chest of the patient. So what are the examination chest finding? Ada tak lepas ni? So chest finding, the keywords untuk bukan. Air trapping, it can occur in acute anything. Contoh macam patients having foreign body ke, patients having acute bronchiolitis, boleh dapat increase epidiameter, cuma dalam foreign body sebelah lah kot. No? So dalam patient acute bronchiolitis, the patient can have hyperinflated chest. So it did not indicate chronicity. So when you examine the chest, apa yang indicates so-called chronic airway obstruction? Azla. Harrison-Sulcus lah. So kalau you memang suspect, you are looking for Harrison-Sulcus. Ada tak gambar you Harrison-Sulcus? Next. Ada tak? Saya tak letak. So this very important Harrison-Sulcus. So Harrison-Sulcus, kalau you tengok chest, dia nak differentiate dengan intercostal recession. Intercostal recession ni dia in, subcostal recession dia in out kan. Cumanya dalam Harrison-Sulcus, dia adalah fixed deflection. So it indicates chronic airway obstruction. So walaupun mother deny of having any symptoms, mother kata tak ada. So tak boleh percaya. Kalau ada Harrison-Sulcus, dia adalah signs of chronicity. Boleh? And again, when you examine, mesti ada rongkai lah. So bila kita bagi nap, the patient need to be having very, kita panggil apa? Fast improvement with your dilator. So yang gambar kecil tu, I suppose yang gambar tengah lah, yang baju biru, yang tepi lengan biru ni, lengan biru. So indirectly lah kot, I don't know what is the diagnosis they put for this patient. So kalau tengok maknanya dia adalah dekat subcostal recession tu, dia ada fixed deflection. But I think this one kira teruk lah. So bila you tengok, there is hyperinflated chest. There is hyperinflated chest and Harrison-Sulcus. Okay. But there is other few differential diagnosis lah for Harrison-Sulcus. Okay.
Prof, nak tanya.
Yep.
Yang Harrison-Sulcus ni only occur in pediatric patient ataupun ada juga in adult patient?
I don't know about that one. Cuma dia indicates chronic airway obstruction. I suppose kalau patient tak control, untuk budak-budak atau orang tua tak pastilah. Harrison-Sulcus sepatutnya boleh berlaku pada adult if I'm not mistaken. Okay. Cuma as my experience, in adult usually they are more of having hyperinflated chest rather than Harrison-Sulcus.
Okay.
Okay, tengok
Thank
ada
you,
tak pakcik tu. Pakcik tu ada dah. Tengok dah budak tu ada pun. So maknanya kan boleh berlaku. Boleh berlaku. Pertama sepatutnya dia lebih hyperinflated chest lah. Sebab kalau ada ni maknanya very bad lah kot patient.
Dia biasanya dia associated with weak bones kan kalau Harrison-Sulcus ni?
No, it indicates, kalau Harrison-Sulcus, it indicates chronic airway obstruction.
Okay. Thank you, Prof.
Another question? Semua ni banyak. I don't know. Mungkin kena repeat lagi. I don't know whether kalau I tanya you dalam exam will be another thing because management tu we put aside first lah kan? Tak. Management I put aside first. Tapi sad to say that in your third year you have to know a principle for the acute exacerbation you nak kena tahu. Tapi untuk kejap when you diagnose the patient tadi I kata severe and ada life threatening. So for your life threatening yang you nak kena tengok I think silent chest. Okay. So patient yang kalau I tanya you siapa Alia, if I ask you what is the signs of what are the signs of respiratory distress? So what is your answer?
Oh, respiratory distress dia ada banyak. Satu macam the using of accessory muscles. Lepas tu tachypnea, and some patient may also have sweating. Lepas tu dia tachypnea saya nak mention ke?
Kata banyak, I kira macam baru 2, 3, 4 je.
Saya baca soalan tapi dia macam dia banyak.
Macam mana ni?
Serious.
I tertukar. I know nak tanya I know what is the signs of respiratory distress?
Yang saya tahu use of accessory muscle tu jap.
Kalau macam tu, you kena elaborate lah dalam imposting you. That
Oh,
one is
ni.
very important. So what do you mean by using accessory muscle?
Waktu.
Oh,
Ya,
using of accessory masa tu
Ni
disebabkan
Google ke apa cerita ni?
Tak, dia tengah buka buku.
Buka buku sama lah. Certain things to be in your brain already nah.
Okey, doktor.
Bukan semua benda. You boleh lah tanya you yang biasa yang susah-susah ke yang tak common, buka lah buku. Tapi yang ni bukan passion collect sekejap nak buka buku sekejap. No, you tak boleh. So certain thing it must be at your fingertip dekat brain tu, readily available when people ask you. I know.
Apa ni use of accessory muscle? Specific with the muscle ke? Sternocleidomastoid and trapezius. Sorry doktor, saya buka buku ni. Okay.
Buka buku maknanya apa?
Maknanya tak ingat lagi, tak faham.
Kita kira apa tu? Kena usaha lebih lagi.
Okey doktor.
Dipanggil apa? Sedar diri. Kena sedar diri. So at your level masa I dulu tak makan pun vitamin. Maknanya kalau tak letih kena makan vitamin. Kalau tak cukup apa kalau tak ada
makan kisah.
perangsang kena cari orang yang nak bagi perangsang. Tak tahulah.
Perangsang.
Fish oil.
Tak boleh rasa.
Saya sebut je lah yang saya, sebab ni macam nota,
berhenti
takibnya more than 20 breaths per minute. Use of accessory.
You ni buka buku edak sangat, salah dah tu.
Oh, tak. Okay.
Mana boleh 20 more than 20 is takibnya.
Naklah.
Nampak sangat tapi nasib baik dah cakap buka buku. So respiratory rate you kena hafal ni. Kalau tak cukup atau I dulu undergrad tak makan vitamin masa 3 years baru makan vitamin on call. Sebab letih lah. Kan tak nak jaga ventilator banyak kan, belah-belah. So kalau letih makanlah vitamin. Kalau kat mana lagi you rasa tak tahulah, tak ingat ni, kalau study dia kena baca, menulis, menyonting. Kan? Sebab tak ada group discussion. So kalau okeylah cakap lah, kalau you kata respiratory distress, okay, you start dengan tengok patient lah. So the first thing you look at the patient will be the head nodding. So head nodding, head bobbing semua sama lah. Head nodding, head bobbing tu kepala dia bergerak-gerak. So those are using sternocleidomastoid muscle. Okay. And then this is using accessory. Kalau you kata accessory muscle, I bagi 0 marks because I want to know what are those. And then you are looking at the nasopharynx, okay, ala nasai, okay, kembang kempis hidung dia. Okay, so maknanya kalau you tengok daripada atas, looking for head nodding followed by nasopharynx. So, bila habis itu, you akan start dengan bawah. Okay? Sebabnya bila the chest, dia duduk bawah dulu which is subcostal recession, intercostal recession, sternal recession, suprasternal recession, infraclavicular recession or supraclavicular recession. So sepatutnya di respiratory distress tu dia start dengan subcostal and intercostal recession first. So if there is no subcostal or intercostal recession and suddenly you can see the patient is having infraclavicular recession or supraclavicular recession, most likely the patient is having foreign body inhalation. Understand? Sebab kalau kata lung, dia biasanya start daripada bawah lah. Subcostal, intercostal, sternal recession, suprasternal, infraclavicular dengan supraclavicular. Is it roughly like that lah dia punya recession. Itu adalah accessory muscle. Okay? Okay, faham? And then the patient must be takibnik. So respiratory rate according to age. So kalau neonates more than 60. So kalau setengah age group more than 50. Setengah age group more than 40. Setengah age group more than 30. So this one, there is no choice for you untuk hafal different age group with the respiratory rate. Because nanti the interpretation whether the patient is takibnik or not, you have to know the normal value. So there is no way for you nak kena tahu. So kalau kata adult, yes 20 kan. Kalau kata 20 is takibnik lah because our breathing is about 16 like that kan. Kita punya breathing. But pediatric lain, dia ikut umur. Okay, so 100 biasanya beza sikit dengan adult. Adult biasanya 100 is maybe 100 more than 100 tachycardic. So kalau pediatric sama, tachycardia is also a sign of respiratory distress. Okay. So kalau patient 110 normal lah kot untuk patient ikut age group. Tapi kalau heart rate dia 160, 170 untuk neonates itu tachycardic. So it can be a feature for tachycardic can be a sign for respiratory distress. Boleh? Maknanya respiratory rate, heart rate, yang recession tadi yang sebut recession, and then
Nurse flaring.
cyanosis, nurse flaring. And then you go by cyanosis. Is it that the patient is having peripheral cyanosis or central cyanosis? So cyanosis. Lepas tu bila sinus, you might want to say about altered sensorium. So comatose is indicates very bad attack, comatose. And special about asthma, hanya untuk asthma patient, you have to ask about the speech of the patient, whether the patient talk in full sentence or not. So hanya untuk asthma. So maknanya in patient who's having asthma, unable to talk in full sentence, it indicates severity. Kan? Hanya untuk asthma. So kalau boleh tak yang lain? Sorry. Sebab dalam pediatrik tak ada yang lain. So kalau adult boleh tak? I don't know lah kan. Tapi maknanya asthma ni bila Nazla you nak present mesti ada. Patient able to talk in full sentence mesti ada dalam PE you. Not just you say conscious and alert. Boleh lepas tu apa lagi lepas tu you will check the peak flow of the patient. So for me peak flow adalah sebahagian daripada physical finding for me lah. Okay, cumanya you comment lah on the effort of the patient, correct technique or not correct, because most kalau pediatric ni kadang-kadang kita tak buat, which is the negligence by the our medical officer. But if you were to perform peak flow, the patient usually everything is about more than 5 years of age lah. Okay, atas pada 5 tahun untuk kita check peak flow. So peak flow ni dia ada pula dia punya ni. I cannot remember now. But how do you know that the peak flow of the patient is normal or not? Ada formula, but I'm so sorry I cannot remember now. Untuk peak flow. Apa lagi So okay. So then barulah you nak pergi ke so called apa tu pulse of the patient, not just heart rate tachycardic. Dalam ni ada tak? Dalam ni tak ada. Which is the Harrison which is the collapsing pulse. Apa dia panggil? Pulses paradox. You tak ada pulses paradox. So untuk asthma, I expect you to answer patients yang kita kata life threatening. Nama lain life threatening adalah status asthmaticus. Status asthmaticus maknanya the patient is maybe altered sensorium, maybe comatose, sinus, okay, and cannot talk in full sentence lah tadi tu, and heart rate tachycardic, using accessory muscle, and when you examine the pulse, there will be a presence of pulses paradox. I expect you to be able to elaborate how you perform pulses paradox. So maknanya baca sikit teknik untuk check pulses paradox, pakai sphygmomanometer tu. Satu kalau kata bedside, misal kata you are senior lah kot, other people are doing things, so you examine the patient. So palpable pulses paradox adalah when you palpate the pulse, usually the pulse in asthma patient will be a bounding pulse, okay, because and tachycardic, because in heart failure, and bounding can be due to as a cause of respiratory distress. Bounding can be due to presence of temperature, okay, and can be due to impending shock, and very, very important, the bounding pulse and tachycardic can be a side effect of bronchodilator. Okay, so those are the reasons why should an asthma patient having tachycardia or bounding pulse. Okay, so bila misal kata dia bounding pulse, it's easy for you to identify, you timing with the breathing of the patient. So if there is some irregularity in the volume whereby there will be a drop in volume during inspiration, itu adalah palpable pulses paradox. But Kalau naik court tak menang lah yang this palpable pulses paradox. So you have to perform a proper pulses paradox using sphygmomanometer. So in exam, I will ask you how do you perform to check for pulses paradox and what are the principle behind pulses paradox. Okay, kalau I biasa I tanya lah. Okay, so this is status asthmaticus. So satu lagi for status will be the yang different from other respiratory distress will be your silent chest. So silent chest here is when you look at the patient in respiratory distress. But this is asthma, so when you examine the patient, there is no rhonchi. Okay, maknanya it indicates severe bronchospasm. So that's why you cannot hear any kita kata rhonchi. Okay, reduced breath sound and no rhonchi. So itu adalah silent chest. But bear in mind, if there is reduced breath sound, especially kalau one side only, you have to think of pneumothorax. Okay, you have to think of pneumothorax. So how do you know pneumothorax? Kalau severe mungkin dia ada push to the other side kan, ataupun hyperresonant, isn't it? Okay, but you can always do the chest X-ray, or you can do, zaman dulu kita buat needling test lah, needle test. But now I think more of we just wait for the chest X-ray. So those are status asthmaticus. So okay, we stop asthma banyak, tapi any other burning question you want to ask? So nanti bila you datang sini, maybe we can concentrate on the management part. Another thing, sebab ni ada overlap dengan next topic kan, about the Alia punya topic. Alia ni short and sweet Alia, because this is very broad and I think you touch pneumonia ni dalam apa dalam long case kan.
Long case betul.
Ayah itu apa you dah present dengan saya kan long case ke no?
Present long
No kan?
Oh yang itu tu fibrifid, tak tahu lah, banyak sangat group dah I confused.
Fibrifid rasanya kita orang tak ada buat. Fibrifid.
Okay. Fibrifid itu the previous group.
Tu group lain kot.
Okay, tak apa. Alia, I tak ada long case dengan you all kan?
Tak ada. Tak ada.
Okay, tak apa. So Alia, anything you want to say? I know lah, sekejap aja I know tu.
Alia ada slide tapi sikit je.
Sikit short and sweet sebab tak naklah lama sangat kan, sikit tekak lah.
Okay, kejap.
But I did not teach you everything about asthma. Shooting from different angle, I tak ajar you semua lagi asthma, bear in mind.
Okay, boleh nampak kan? Okay, so my topic for today is pneumonia. Alright, so by definition, pneumonia means infection or inflammation of the lung parenchyma. For the incidence, viral infection is more common compared to bacterial and fungal infection, especially in children aged younger than 5. And some books say in children aged younger than...
Alia, so yang macam ni I tak suka bila I tak suka bila you present. I know you want some introduction, tapi dia macam terus straight to the point yang very very important point lah.
Oh, okay. Nak kan, important punya. Alright, classification of pneumonia basically kena tahu ada 4 lah: community acquired, hospital acquired, healthcare and aspiration pneumonia. Alright, so ini yang quite important punya pathogenesis and pathophysiology of pneumonia. So basically what you have to know is in normal healthy person, you won't get pneumonia because when the organism tried to invade your respiratory tract, it will be expelled. So these are the susceptible hosts that cause the infection to occur. Right. So for pediatric, you can see from the immunological part, which is we can see whether the patient is immune compromised, and for environmental, if secondhand smoke or air pollution, exposed to air pollution, because this pollution or this smoke is basically can irritate the respiratory tract. And then for hospitalization, it depends on the length of stay, the recent antibiotics used, and also mechanical ventilation like ventilator, because if the patient is on ventilator, then it is most likely it has higher risk of getting pneumonia, since the ventilator is the only source of oxygen you can get. And then so these are the susceptible hosts, and what happens is that the susceptible host is exposed to pathogen. It can be via inhalation, hematogenous, direct or aspiration. So infection will occur and there will be proliferation of pathogen in the lower respiratory tract or the lung parenchyma to be exact. Right. So when there is pneumonia occur, so there will be inflammatory response with regards to the proliferation of the pathogens. So there will be local and systemic inflammatory response. For local, so the neutrophils will somehow be recruited to the site of infection. So there will be accumulation of plasma exudate from the capillary leakage at sites of inflammation. So this will lead to irritation of airways. Alamak. Right. So this will lead to irritation of airways and the failure of ciliary clearance to keep up with the fluid buildup, because there will be increase of the fluid buildup, but somehow the ciliary clearance is failed to keep up. Okay, and so the patient will present with cough and crackles due to the fluid buildup and also reduced breath sounds. And also, if the fluid buildup in spaces between the alveolar, then the pattern will show interstitial pattern. And this can be seen in the chest radiograph. And then if the fluid buildup in alveoli, there will be lobar pattern. So kita akan nampak lobar consolidation on chest radiograph. And then bila berlaku accumulation of plasma exudate, there will be reduced in efficiency of gas exchange. So this condition will somehow lead to hypoxemia. So our body will try to compensate the hypoxemic condition. Then the patient will present with tachypnea and also respiratory accessory muscle use. And the patient may show chest indrawing, paradoxical breathing, and also muscle retractions. Paradoxical breathing is basically means that usually when we inspire, our chest will expand, and when we expire, our chest will go inwards. But somehow in paradoxical breathing, it's basically the opposite of it. So when you are during inspiration, your chest will be indrawing, and then during expiration, your chest will expand. Right, and so for systemic inflammatory response, there will be cytokine release. So the cytokine release will cause increase in respiratory drive that will also lead to tachypnea and also disruption of hypothalamic thermoregulation, which will cause fever and chills. Right, so these are the clinical presentations. I divided into viral and bacterial pneumonia. Oh, I forgot to mention that bacterial pneumonia is basically more dangerous as compared to viral pneumonia. Alright, so for viral pneumonia, the patient may be presented with rhinorrhea or runny nose, cough, usually non-productive, fever, which is low-grade fever, less than 39 degrees Celsius, pharyngitis, lethargic, refuse to play, have difficulty feeding due to tachypnea or cough, and in very young patient.
I did not really agree
Sorry?
with you. You have class yet regarding this pneumonia. First time tengok ke slide ni?
This one I took from the book.
I know. But so
Okay.
far, but I know this is first week. Ini first week kan?
First week,
Tapi
first day.
previous rotation, you pernah ada ke tak ada pernah lagi discuss about pneumonia?
Kalau ada pun just a little bit of it. Just a
Because
small.
kita go by the standard. I go by basic teaching lah, basic teaching. When you talk about viral pneumonia, for me when I say bronchopneumonia, meaning that bacterial pneumonia. For me setengah lecturer dia mungkin different. So you tak payahlah jadi batu api But to say that, for me when I say bronchopneumonia, meaning that bacterial pneumonia, bila I kata viral pneumonia is a viral pneumonia. So I won't say pneumonia saja. Bronchopneumonia for me is bacterial pneumonia. Okay. So kalau kita kata standard teaching, standard common sense, okay, viral pneumonia ni is something like you mentioned just now, isn't it? Which is something that easily to control, isn't it? And it won't really give problem to the patient, kan? So that's why kalau I tak tahulah buku mana you ambil ni. But for me, kita ambil dah, kalau kata viral pneumonia, satu, the fever is low grade fever. So that's why kalau kata bila kita tanya you dalam end posting, how do you know that whether this is bacterial or viral? So the keyword, the first one will be, the patient will be having high grade fever in bacterial and low grade fever in viral. Okay, satu. Satu lagi is that viral pneumonia usually it is not really associated with reduce in activity of the patient or reduce in oral intake of the patient. So usually it is not really. So unless, understand?
Mm-mm.
Okay, so kalau
Faham?
kata bacterial pneumonia, so usually dia akan affect the patient's punya daily activity, meaning that reduce in activity, and the patient usually can have reduce in appetite, maknanya reduce in feeding. So kalau kata feeding in children dia ada dua, whether appetite dia bagus ke tak ataupun appetite ada but each time dia nak minum tapi dia akan batuk. That one is different thing. Bila dia minum dia batuk. That one is different thing kan because dia ada
Mm-hmm.
coughing. So that one is different thing. So that's why kalau tengok situ have difficulty feeding due to coughing. So dia batuk. Dia bukannya reduce in appetite.
Mm-hmm.
So kalau kata viral pneumonia, patient usually still play.
Still okay lah.
Boleh lah. Maknanya to say that
Mm-hmm.
in a patient with viral pneumonia, the patient should be okay. However, when you have any viral pneumonia or acute tonsillitis or pharyngitis, due to viral infection, your body will be, your mechanism, your body system will be reduced. Okay, your immune system will be reduced. So it will make the susceptibility to the secondary infection. So this secondary infection is the bacterial infection. So that's why once, if you say that viral pneumonia, but the patient is having reduced in activity and reduced in feeding, so usually it is already superimposed with secondary bacterial infection.
Mm-hmm.
Boleh? So maknanya kalau I kata expect you will say that everything is okay for viral pneumonia. Okay,
Okay,
bacterial
faham.
pneumonia no. So maknanya you have to admit the patient, you need to give the antibiotic to the patient. Okay, whereas for viral pneumonia there is no treatment unless supportive treatment. Supportive ni maknanya bisa kata ada demam. So mungkin you want to give paracetamol. So kalau in some patient okay lah dia teruk sikit batuk, so kan, so you want to give oxygen. Okay, that's all. So kalau patient dah ada reduce in activity, usually kita akan cover with antibiotic because kita akan anticipate that there is some secondary bacterial infection. So
Okay,
boleh
faham.
So I cut short yang ni. So you
Okay.
ambil yang standard macam tu. Kalau macam ni I don't know, you yang confused lah, macam mana nak bezakan. So kita ambil yang biasa-biasa saja nah. Okay,
Okay.
Okay.
Thank you, Prof.
So next tu I cut short because kalau tidak I nak berhenti dah ni.
Okay. So next is about the physical examination. So these are the findings. So the patient may be irritable. Ini untuk viral infection
yang
and
ni pun
toxically ill or anxious in bacteria.
So if you
Yes.
say irritable is very powerful. For me powerful. Maknanya when you say the patient is irritable, then you have to exclude meningitis until proven otherwise. I don't know lah, buku memang guna macam tu lah. Sebab dia tak akan guna fretful. So kita biasanya kalau you present, you akan guna perkataan fretful. So kalau irritable ni biasanya masuk dalam group yang tak elok sikit lah. Okay?
Oh,
So,
faham.
kalau daily activity you, kalau you tak rasa something yang to deal with the meningitis, you guna fretful. Kalau irritable ni, you are using for a little bit severe condition. Okay? Kalau kata viral, tak jangan guna irritable, guna fretful. Okay?
Okay. Thank you, Prof. And I guess the rest has been discussed earlier.
Okay, that one satu lagi wheezing tu.
Yeah, wheezing. Yeah, betul.
Wheezing ni, you said bronchopneumonia. So ingat bronchopneumonia, keywordsnya broncho, okay lah, is it viral or is it bacterial pneumonia? But when you examine the patient, the keywordsnya adalah crepitation, crackles, okay? Crackles ataupun crepitation. So bila patient wheezing, it is not a signs for pneumonia. I don't know which book you ambil ni. Okay boleh? So rongkai wheezing ni yang kita dengar with our naked ears. Wheezing ni kalau bagi saya, kita ambil yang standard teaching. Wheezing ni something yang kita dengar without stethoscope. So okay, so there are 5, I dah ajar ke 5 respiratory noises? Dulu ada ajar dah, I confused dah banyak-banyak kelas ni kan.
Yang wheezing, rongkai,
Ada?
tak, doktor tak ajar, tapi macam adalah pernah terbaca.
Okay, there are 5 respiratory noises. Okay, the first respiratory noises kita ambil wheezing, second stridor, third will be your grunting.
Course crackers.
No,
Oh.
no, no. This is by naked ears. Naked ears ni maknanya by using your ears, not using stethoscope.
Okay.
Okay, so the first respiratory noises is your wheezing, second is stridor, third will be grunting. Okay, fourth will be your snoring, and fifth will be your rattling. Rattling. So the wheezing, typically it is Paira, I tanya you tapi tak apalah. Wheezing is basically expiratory wheezing. Okay. Stridor, Baira, inspiratory. Okay. Inspiratory.
Betul.
However, in foreign body inhalation, it depends on the severity of obstruction, and also it depends on the level of obstruction. So in foreign body or certain lung problem, the patient can have expiratory stridor and the patient can have inspiratory wheezing. So it depends on the level of obstruction and also the severity. Maknanya kalau nearly complete obstruction, bunyi lain sikit lah. Understand? Cuma kalau kata typically wheezing is expiratory,
Stridor is inspiratory.
stridor is expiratory, and grunting is expiratory. And grunting usually it occur in neonates in respiratory distress syndrome, neonates ex prematurity, or in term patient yang mungkin infant of diabetic mother, RDS. In general ward in 6S, we can hear grunting in smaller infant with bronchopneumonia, okay, in severe bronchopneumonia. But not in bigger child lah. Grunting I tak pernah dengar bigger child, okay. And snoring basically it can occur in us. I mean yang tak ada, with due to our adenoid ke apa ke kan, snoring. And the last one is rattling. So rattles basically is a secretion. Okay, bunyi secretion dalam tekak tu, dalam perut tu adalah rattle. So this is respiratory noises, 5 respiratory noises. For stator ni dia atas ke bawah sikit daripada stridor. However, stator is not there in the standard textbook. Stator, it is present only in ORL book. So dia bukan standard lah for ni. But in the ward you can see that certain ENT doctor dia akan menggunakan perkataan stator lah. So bunyi lebih kurang macam stridor. So for your duty is to learn about the mechanism for these respiratory noises. So those are your basic. So maknanya when you talk about the mechanism, you have to talk about intrathoracic and also intra-abdominal pressure. Okay, boleh? Boleh faham? Okay, lepas tu I nak kacau you. Apa lagi you nak cerita ni? Because I think at your level, you baca pneumonia, we will learn about pneumonia. I think so. But another thing, when you clerk a case, very, very important for you to know how to differentiate between the differential diagnosis for all these things. So I think tak apa, you tunjuk yang mana I tak suka. Sekejap . Yang ni. So you tertinggal CRP you ke? So always do the full blood count dengan CRP, because that one is the key points for you to differentiate whether this is bacterial or viral. Okay, CRP will be elevated usually in bacterial infection, and usually it is not elevated in viral infection. So CRP will guide us. Okay, blood culture ni tak apalah. Apa lagi? Just X-ray. Sputum pula. So it is not really a sputum. Okay. Sputum, I think you ambil dah buku besar kan, buku adult. So untuk patient ni dia lebih kepada what we call nasopharyngeal aspirate, isn't it? Nasopharyngeal aspirate. Usually we are not sending for gram staining. Kalau kata in pediatric, as you mentioned your first slide, it is viral infection. Kan? So kalau kata nasopharyngeal swab untuk pertussis, PCR, nasopharyngeal aspirate untuk viral. Okay. So kita tak pernah send kita kata sputum ataupun nasopharyngeal untuk tengok strep pneumonia. No, kita tak pernah hantar. Okay,
dalam buku dia kata dia kata more than 12 years old.
Yelah, that's why lah. So kalau you tengok dalam ward, how many patient yang datang sebagai pneumonia? Very rare. Very rare.
Right, betul.
More than 12. So that's why kalau go by this, I'm not happy lah. Mana kalau you dapat case yang lain tu kan. So you boleh letak sputum test for bigger child. It's okay, fair enough your investigation. But not you putting like this. Maknanya tak ada comment that you don't know kan. So for me, as I mentioned, mycoplasma adalah duduk dalam physical examination sama level dengan BP tu. Pulse oximeter for me is not an investigation. Unless you do some maneuver ke apa ke, okay lah, fair enough lah investigation. Okay, serology kat sini. So serology not just mycoplasma pneumonia. So kita panggil viral serology. So viral serology other than your nasopharyngeal swab tu, you might want to take viral serology. Contoh Epstein-Barr virus kan. So you sample that. Okay. Tapi selected viral serology. Sorry, I tak suruh you present supaya buy time. Okay, faham? I comment je lah, but tak apa. Next, investigation. So, apa yang tak ada dalam ni? Apa yang tak ada? Okay, enough lah kot Next.
Next is about the management. But usually the infection is due to viruses, so kita tak perlukan antibiotics pun.
Tak, mana ada. Kalau patient yang viral pneumonia, dia tak akan masuk ward.
Betul.
So, yang masuk ward ni, kena start
Usually yang bakteria,
so start lah.
ada explanation dalam ni. Ya, betul.
Anything you want to say? Jangan cerita panjang.
Okay lah, kita pergi kepada inpatient
management. Sorry ya, sebab banyak benda.
Tak apa. Lagi pun library pun dah nak tutup ni. Okay, inpatient management.
Nak habis masa dah? You duduk kat library?
Library sebab internet dah habis.
Okay, tak cakap lah. Okay.
Tak apa.
Sempat lah.
Sempat kot, dia kata pukul 5 tadi tutup.
Okay.
Right, so for inpatient management, biasanya yang patient dah memang severe punya pneumonia, so memang kita akan treat with antibiotics. So these are the sequence. The first line, we will give beta-lactams. Second line, okay. Tak payah. Okay, supportive management.
Pergi ke differential.
Differential, okay.
So this one, you tak akan dapat markah. You mention about this one. Okay. Kalau kata...
Kau nak difference between viral and bacterial tu?
No. Bila you dapat case, okay, this is a real life punya ni. You dapat case, patient, chief complaint, fever for 3 days, associated with cough and runny nose. Associated with cough for 2 days and rapid breathing for 1 day. Okay, the chief complaint dia. Boleh? Fever, cough, rapid breathing. 3, 2, 1. So what is your differential diagnosis? So kita ambil umur patient sebagai 6 months. Ataupun 8 months. Okay, kita ambil 6 months lah kan. So kita ambil 6 months. So first, kalau kata ni apa, you akan letak bronchopneumonia first lah kan. Sebab untuk budak kecil, you want to start antibiotics. Okay. So what is your differential? Okay, viral pneumonia. Untuk pneumonia, you akan ada dekat berapa jenis pneumonia, tahu tak? Okay, satu kalau you letak patient, okay, kita kata boleh ya. First differential is viral pneumonia. Okay, kalau macam ni ada satu lagi which is URTI, whether the patient is having acute tonsillitis or acute pharyngitis. Is a differential diagnosis. Okay, boleh. Upper respiratory infection lah tu. Maknanya viral pneumonia, URTI. Nombor 3, it can be aspiration pneumonia. Okay, it can be aspiration pneumonia. Aspiration pneumonia here adalah milk, okay, milk, feeding of the patient, aspiration pneumonia. Okay, if the patient is having respiratory noises, wheezing ataupun stridor, kita ambil wheezing lah. Okay, wheezing. So the fourth differential ataupun mungkin the first differential diagnosis will be your acute bronchiolitis. Okay, acute bronchiolitis. Okay, kalau patient cross 3 years of age, acute bronchiolitis will be replaced by viral induced wheeze. Ataupun you cakap dua-dua selalu, tak apalah, because acute bronchiolitis it is for less than 4 years of age. Okay, viral induced wheeze. So dekat-dekat dengan viral induced wheeze adalah multi-trigger wheeze. But this multi-trigger wheeze usually bigger child sikit, mungkin umur 2 tahun and few episodes of wheezing. Boleh? Multi-trigger wheeze. Okay. Nombor berapa dah? Lepas tu, kalau ada respiratory noises, you not so sure is what, then your pertussis. Pertussis is prolonged is a bouts of dia panggil apa? Bouts of prolonged cough followed by facial congestion or post-tussive vomiting. So pertussis. Okay. Kalau patient dah mungkin mobilize sikit-sikit, dia boleh reaching for object, then you can say foreign body inhalation. So foreign body inhalation and aspiration pneumonia is different. Boleh? Okay, satu lagi pneumonia will be your atypical pneumonia. So usually atypical pneumonia, you suspect bila patient ada eye discharge, that one untuk Chlamydia trachomatis. But if the patient bigger, more than 3 years, atypical usually Mycoplasma pneumoniae. The other organism other than Mycoplasma, Chlamydia trachomatis will be your Coxiella burnetii or satu lagi apa? Coxiella burnetii and Mozzarella catarrhalis. So ada 4 semua atypical pneumonia. But only Mycoplasma pneumonia we can do in our center or in Malaysia, I suppose. The other 3 you go by, you suspect sajalah. So bila kita kata atypical pneumonia, meaning that the treatment will be with macrolides or azithromycin or erythromycin. Another thing about atypical pneumonia ni adalah the patient will be having the symptoms of the patient did not correlate with the radiograph of the patient. Maknanya the patient is quite well, okay, minimum crepitation for example. However, when you do the chest x-ray, very bad chest x-ray. So that one macam TB kan. So TB is another entity lah. TB, okay. Satu lagi will be when you look at the patient is severe, you have to admit the patient in ICU. However, when you do the chest x-ray is clear. So untuk atypical pneumonia dia ada 2. Maknanya terbalik yang tu. So either one is up to you. But to say that the clinical manifestation did not correlate with the chest radiograph. Boleh ha? Atypical pneumonia. Okay, the next one will be the apa tu kita panggil congenital. I rasa you nak kena keluar dah ke? Congenital malformation. So congenital malformations here will be vascular ring for example. Kan dia duduk dekat dengan trachea tu contributing to respiratory noises. Okay? Vascular ring. Okay? And next abnormality will be your tracheoesophageal fistula. So that's why I gave you the small h. So this tracheoesophageal fistula TOF will be H-type TOF. Okay, H-type TOF. Next will be apa? Congenital malformation. If stridor I put aside dulu. Ni adalah wheezing baru. So the next one will be heart failure. So how do you know that the patient is a case of heart failure? Maknanya macam mana simptom dia? Heart failure ni usually sebab patient kecil, you did not really ask for reduced effort tolerance, isn't it? Dia tak berjalan. So the things that you can ask is that, is there any sweating during feeding? Or is there any prolonged, dia panggil apa? You nak off dulu boleh ni, suara lain je lah dengar. So apa benda?
Saya dengar sambil berjalan.
So taking a longer time to finish the feed. Okay, taking a longer time to finish the feed ataupun dia panggil interrupted feedings. Because of this, the patient will be having poor weight gain. Another thing will be sweating during feeding. So kalau patient ada 4 ni untuk patient 6 months, then you can suspect that the patient is having heart failure. Okay, ini adalah untuk patient yang bila you examine the patient, there is no clubbing. So kalau patient ada clubbing with wheezing, then you can entertain like mentioned just now, the cystic fibrosis, bronchiectasis, okay? And bronchiectasis ni ada 2. Dalam kes ni is primary bronchiectasis or secondary bronchiectasis. So secondary bronchiectasis will be due to immunocompromised cystic fibrosis. So untuk cystic fibrosis, bronchiectasis, there will be a presence of clubbing. So satu lagi yang hyperactive airway disease. Semua yang saya sebut ni adalah hyperactive airway disease. Satu lagi will be the chronic lung disease or other name will be by BPD, which is bronchopulmonary dysplasia. So chronic lung disease usually in a case with X prematurity requiring oxygen ataupun ventilation up to 28 days, okay, with the positive respiratory changes in the lung, okay, by chest X-ray or CT thorax, okay. So itu adalah chronic lung disease. Treatment sama macam asthma. However, because your lung maturation is outside, okay, so lung maturation is about 5 years of age. So this chronic lung disease by right should be disappeared by 5 years of age, okay. Apa lagi? Sorry, tak tersebut adalah your asthma lah. So asthma duduk atas lagi ya. Cuma asthma ingat ya, untuk entertain asthma ikut age group. Okay, satu ikut age dia dan satu lagi strong family history of asthma. So kalau patient umur 2 tahun masih boleh entertain asthma dengan syarat strong family history of asthma. So remember kalau you letak diagnosis macam ni fail. Sebab COPD is for adult. Faham? Yang you letak semua tak, bagi I won't be happy with you. So faham? But if you're talking about pleural effusions and pneumothorax, itu adalah complication related with asthma untuk untuk pneumothorax, pneumonia dia akan complicated by pleural effusion. So dia bukan as a differential diagnosis, dia adalah complication. Okay, kalau pleural effusion dengan pneumonia dipanggil parapneumonic pleural effusion, okay? Because pleural effusion can be due to CA kan, it can be due to apa dia panggil? Dia panggil apa tu? Yang nephrotic syndrome. So itu adalah pleural effusion. So untuk complication pneumonia dipanggil parapneumonic pleural effusion. So kalau kira ni lebih pada 10 kan dia punya differential diagnosis. So kalau dia ada stridor, ada 3 yang you nak kena tambah, which is your epiglottitis, your croup ALTB, and then your laryngomalacia. Okay, your laryngomalacia. The others I think some overlapping. Maknanya bila you cluck, is there any respiratory noises or not? Okay, banyak nak. Cumanya kalau dalam M posting, this differential diagnosis you kena tahulah. Maknanya kurang-kurangnya sebut 5 differential, 1 provisional. Okay, ada soalan ke? Untuk pneumonia ni, saya tak sempat lah nak ajar semua sebab masa. Kan boleh tanya dalam next session lah. So sama juga dengan I know nanti boleh tukar yang lain, but I think yang last I know kan?
Saya.
I know you are the last person.
Ah.
So anything you want to say about your topic? Nanti Alia nak tanya lepas ni biar I know say something dulu.
Okay.
Saya baru keluar dari library ni.
Dia keluar lah, tak apa. Tapi tak ada line lah tu. Tak ada line tak apa, kita orang 3 je lah. Berempat.
Saya
I know nak cakap apa-apa.
Saya cuba pendekkan okay, sebab okay, tak apa, saya cuba pendekkan dulu. Okay, so untuk hemolytic uremic syndrome, kita kena faham dia characterized by 3 things. Microangiopathic hemolytic anemia, maksudnya kalau kita buat peripheral blood film, kita akan nampak.
No need to, because you nak present something is not core. Bila tanya yang basic you tak boleh jawab lagi. So that's why concentrate yang basic dulu, because HUS is for distinction student. Bukan kata you bukan distinction, tapi you have to know, you have to know about pregnancy. I know we discussed already about nephrotic syndrome kan. Dia duduk dalam differential diagnosis for AGN nephrotic syndrome, IgA nephropathy. You duduk kat situ. So if I ask you what is the overfilling, underfilling, can you answer my question?
Enak doktor. Pernah dengar je. Saya pernah terbaca waktu hari tu yang ada waktu saya present AGN itu ada baca rasanya underfilling, overfilling, tapi saya tak ingat.
Underfilling ni adalah suatu kewajipan ataupun suatu core knowledge untuk nephrotic syndrome. Overfilling, underfilling. So that's, for me that one is more important because nephrotic syndrome is your core knowledge. AGN, these two adalah core knowledge. Okay. HUS adalah sampingan bila you cerita about this thing, that is your differential diagnosis. So okay, betul dah you kata MAHA tu kan, microangiopathic hemolytic anemia tu. Okay,
lepas tu
so lagi maknanya you will do the COMTEST ke apa?
Contest dia negatif.
Okay, maknanya you akan ambil untuk HUS ni, the keywords is that dia akan ada special cell, isn't it?
Schistocyte.
Dekat mana?
Peripheral blood film, if I'm
Peripheral blood
mistaken.
smear. Peripheral blood smear, HUS. So what
Ah.
happened to the patient lagi, kalau kata urine dia, tak apa lagi yang so special. Ingat dia ada MAHA, microangiopathic hemolytic anemia. Your contrast is negative. Okay, satu lagi will be your thrombocytopenia kan?
Yes.
And
Thrombocytopenia.
then you do the peripheral blood smear, dia akan ada presence of this abnormal cell. Okay. And dia very, very ill. Patient will be very, very ill. And usually the patient is ventilated. So that's why bila Hausman level pun, kalau kata Hausman level, HUS will be managed by medical officer. But yalah, kadang kita tanya juga HUS, not to say that you don't have to know. Cuma kalau kita tanya you overfeeling, underfeeling, by right this one you kena boleh jawab dulu. So maknanya kalau kata study smart, kita pilih mana yang ni dululah. Bukan kata tak, no, this is why it's very good topic. Cuma kalau I try to guide you to cari yang benda yang lebih kita kata produktif lah untuk you kan. Core knowledge. So anything else you want to say about HUS?
Saya tak tahu sebab nak saya sebut terus ke differential diagnosis ke?
What is your differential?
Yang saya jumpa dalam up to date lah, DIC, thrombotic thrombocytopenic purpura dengan systemic vasculitis.
So to say that this patient is having thrombocytopenia, so dia adalah look ill. So kalau you want to imagine this patient is very ill and usually dekat ICU setting. So bila thrombocytopenia, what is your differential? Definitely lah the IVC. So how do you know the IVC ni? You will do your kita panggil apa?
Coagulation profile.
Coagulation dengan apa ya Allah, tak ingat dah. Sebab sekarang dia berubah-ubah. Allah tak ingat dah. Di IVC kan dia how to diagnose kan. So maknanya dalam kes ni it will be normal lah sebab dia bukan di IVC kan.
Setuju.
So okay, lagi apa lagi nak highlight?
Sebab yang approach tu je lah kot yang saya send dalam group tu. Sebab doktor kata
baca sendirilah yang tu. So
yang
bagi
tu je lah.
ingat kalau patient ni dia akan datang dengan urinary symptom. So you need to know yang nephrotic dengan AGN for me lagi core lah.
Core knowledge. Okay,
thank you. I know tak apa, markah tu saya tengok effort semua dapat markah effort.
Tak apa Zat, hari tu Zat, saya pun minta maaf sebab saya buka lambat WhatsApp hari tu. Lepas tu saya macam tanya kawan saya apa yang dia orang buat. So dia ada
maknanya kalau tanya you apa yang you nak belajar, bagi saya that's why I tak arahkan. Sebab apa benda yang you rasa you weak, bukan apa benda yang you excellent. Sebabnya apa yang kita nak spend masa untuk kita dah excellent. So apa benda yang you weak, you tak tahu, so that you want to clarify, you akan buat extra effort to prepare the slide ke apa benda, something yang you weak, bukan something yang you excellent. Kan? Sebab kita adalah untuk belajar, bukannya untuk, ialah belajar semua benda lah. Bukan yang dah pandai tu tak apalah, pandai tu it's okay lah, very good lah kan. Tak apa, tak ada masalah. Ada apa-apa lagi yang Alia tadi tu sekejap ada ke tertinggal. So I think differential diagnosis pun dah cukup dah sebenarnya. So bila you dapat differential diagnosis tu, you akan baca according to the differential diagnosis tu lah kan. So kalau kata asthma tadi yang Nazla tadi, actuallynya kalau smaller patient ikut age group. So kalau patient umur 1.5 2 tahun, biasanya kita panggil recurrent viral induced wheeze or multi-trigger wheeze. Atau adakah dia chronic lung disease before you say that okay this is asthma case. Okay. As I mentioned, 2 years pun boleh diagnose asthma dengan syarat strong family history of asthma. So kalau kata asthma, how you differentiate between acute bronchiolitis and asthma? Satu tengok age group. Maknanya acute bronchiolitis must be less than 4 years of age. Tapi dua-dua case akan ada chest hyperinflated chest. Acute bronchiolitis hyperinflated chest, asthma hyperinflated chest. Tapi dalam acute bronchiolitis tak ada Harrison sulcus. Okay? And eczema will be there for asthma. the other name for acute bronchiolitis adalah happy wheezer. So dia ada wheezing but they are very playful and very smiling to you, tapi dia takipnik. Okay, dia takipnik. Kalau kata asthma, tak pernah patient tu cheerful macam acute bronchiolitis, because to certain extent I think bronchospasm in acute bronchiolitis is different from bronchospasm in asthma. Okay, satu atypical pneumonia. So kalau kata atypical pneumonia, usually kalau mycoplasma, it is in school age group. Okay. And other name for atypical pneumonia adalah walking pneumonia. Maknanya the patient maybe nampak macam okay. Okay, macam TB walking pneumonia, but when you auscultate, there will be a presence of crepitation maybe. Apa lagi nak highlight? Okay. Untuk asthma, other than apa yang tadi very fast lah. Kita dah highlight kan, very fast improvement with your salbutamol. Apa lagi nak highlight? Okay, ada soalan ke? Nak berhenti dah, pukul 5 dah kan? Boleh berhenti dah ni, lama dah. Okay, shall we stop now?
Okay je. Doktor, untuk next week tu
I tak tahu next week sebab I biasanya orang yang suka, I dah suruh Dr. Syidah tukar because saya akan mengikut jadual biasanya. Cuma last week tu I dengan group lain tu I was very busy hari tu, hari Ahad, I cannot cope. Tapi dia orang cancel. So cancelling without me, yang cancel is not good for your attitude. You boleh tolak markah, you tahu tak? So it is me yang kena cancel, bukan you yang cancel. Because I think dari segi belajar, you always need to be ready. Because kalau kata you tak prepare, I think jangan kita kata stress. Portfolio ni is for our template untuk kita study. Kan? Betul tak?
saya
The
setuju.
benefit is for you all untuk you clarify things. So kalau you tak prepare, you want to ask me question. Dengan syarat you dah discuss, you do your part. But this is the things that you want to clarify. Okay je you tak prepare apa-apa. Because the keyword is you improve in your knowledge. Because ya kalau you present pun tanya tak boleh jawab, tak guna juga kan. Kalau kata dalam masa setengah jam discussion, okay je. Sebab you maybe have discussed among yourself and you just want to clarify. So setengah jam mungkin okay. It's a productive thing. So bukan kata setengah jam tak elok, 2 jam setengah macam ni elok. No, it is not really. Tapi yalah kadang-kadang mungkin you want to, different angle you punya angle student macam tu. Kita different angle as a specialist, dengan examiner mungkin different angle. So you might want to learn what is the angle. So fair enough lah ya. So bagi I many ways for us to learn. Okay, apa lagi ya? So next week tengoklah macam mana. I pun tak tengok lagi jadual next week, hari Ahad depan. Because tomorrow I have class with year 5. So and then exam. So I cannot cope doing another session with you. So kalau hari ni dah letih lah macam tu kan. Sebab esok ada year 5 punya ni, dengan I have to concentrate on my master student ambil exam. Dia exam minggu depan. So I think kalau minggu depan kejap hari Isnin tu hopefully boleh, because I will be the examiner hari 6 hari bulan 4 tu. Hari apa 6 bulan 4. So kita mungkin hopefully kita buat hari Isnin petang tak better tak daripada hari Ahad. Hopefully.
Petang rasanya ada kelas tak?
You
Jap.
pula ada kelas. So
Nanti kita orang punya jadual kat doktor.
Kalau tidak kena buat pagi. Kalau tidak pagi, I think ada clocking time ke apa benda tu. Kalau you tak involve dengan clocking, masa tu kita buat pukul 10 dengan, kalau nak sekejap is okay. Kalau kata sejam, bagi I okay je. Tapi you nak lama, is up to you. And then you prepare with the question. Lebih produktif kot. Sebab bertanya soalan mungkin lebih benefit daripada I cerita, mungkin you dah tahu kan? Betul tak?
Tak ada, doktor cerita bagus. Banyak benda tak tahu.
I cerita ni yang mana yang penting lah. Cuma I tak ajar you pathophysiology, I think you baca sendirilah. Ajar pun kadang masuk telinga kanan, telinga kiri. Talking about something yang clinical apply, I think that one you tak ada dalam work kan, is more useful lah. Okay, tak apa. Apa-apa nanti kita communicate dengan WhatsApp. Minta maaf kalau ada tersalah bahasa ya.
Thank you doktor. Thank you,
Okay,
Prof.
Terima kasih banyak,
sweet
Prof.
ataupun.
Thank you,
Okay,
Prof.
Assalamualaikum.
Salam.
Salam.
Sorry ya, I punya tak ada video because this is my desktop.
It's
Oh,
okay.
tak apa, tak apa.
Okay. Bye.
Tak.
Bye.
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 Okay.